Our next presentation is Dr. Tiarney Ritchwood. And the title of her, I will say that the spelling of her last name was incorrect in the program, and we apologize. It's Ritchwood. But the title of her presentation is My Best Friends and My Worst Enemies, Understanding the Roles of Families in Retaining South African Adolescents Living with HIV in Care.
Mouthful. Thank you. Good morning, everyone. So I am new faculty. I just started in August in the Department of Community and Family Medicine. And I'll be talking about work that I started during a Fogarty Fellowship a couple years ago, and focusing specifically on the adolescent data. So AIDS-related illnesses are among the leading causes of death for youth worldwide. And we saw about a 50% increase between 2005 and 2012 in HIV-related deaths among adolescents. Most of us are aware that 80% of adolescents living with HIV reside in sub-Saharan Africa. And my work is focused on South Africa. So when I got there during the Fogarty, I learned that most adolescents in the clinic that I worked in were transitioned to adult care at the age of 13. So they were in the midst of a healthcare transition program to help them to be more prepared. Because what we found was that between 13 and 25, at least in this clinic, we were losing most adolescents during that time, and they were returning to the clinic when they had more advanced HIV disease. So the clinic, and I don't think this is specific to the clinic that I work in Cape Town, overall they've been more successful in engaging children and adults. And the purpose of this project was really to understand what the challenges were for adolescents living with HIV. So we were looking at social structural determinants of treatment retention and adherence, and focus on Cape Town and surrounding townships. So this project was conducted between May and September of 2016, townships in the Western Cape. We interviewed 59 participants, and that included stakeholders and adolescents living with HIV and their caregivers. And we were partnered with the Desmond Tutu HIV Foundation, which is part of the University of Cape Town. We used thematic analysis, so this is a picture of my research team, and two of the three of us independently reviewed and coded all of the transcripts. We used Atlas TI, and our primary questions focused on the family. So we had a lengthy interview guide, but for this presentation, we're just gonna focus on those that involved the family, because we found that the families were a key piece in whether or not adolescents were retained in treatment. So our main question was, tell me how your family is involved in HIV treatment. And we included a number of prompts depending on what adolescents would say. So our youth were between 13 and 18, and average age was 15. Most of them were female and had at least some high school education. Caregivers were between 26 and 64, and average age was 41. And our stakeholders were similar, between 23 and 64 years old. Average age was 35. So the way we were thinking about this and looking at our data, it's really rudimentary, but the barriers that we identified had to do with instability at home, lack of disclosure, and low HIV education, which really led to poor retention and care based on the responses of participant, and more issues with treatment adherence. Family support was something that came out really strongly in our interviews. And we were able to tease apart. Often when you look at different studies, social support is kind of lumped into one category. And looking at our transcripts, we were able to separate it into these four groups: instrumental, informational, appraisal, and emotional. So instrumental support was the most frequently cited type of support that was helpful for retaining adolescents living with HIV in care and improving their retention to treatment. And instrumental support has to do with tangible forms of assistance or some type of aid. And this is from a caregiver who talked about the importance of establishing rituals, planning ahead, and monitoring adolescents taking their treatment. And in this case, it was really a family affair. So she says, if we're going out, we're going to come back late. Everyone takes their pills with them. I've got small plastic sachets, which I put the tablets in. So they just put their tablets in their pockets and the water bottle is always there. We have a ritual at home. Whoever's around me and hears the alarm going off at 2100 just goes to the area where the children are and screams out, the time is 2100. You'll see them leave the other children, come into the house and take the tablet. And the caregiver in this case really established the importance of watching the youth swallow the pill. Informational support was also very important, and what we found was that caregivers are normally seen as the primary source of HIV education, specifically from the adolescent perspective. So instead of asking their providers in the clinics, often they would ask their caregivers HIV-related questions. And a number of them talked about the challenges of communicating with providers, and in this clinic, there are a number of initiatives focused on helping staff to be more adolescent friendly. So that was something that I'm not going to have time to talk about in this presentation, but came out very strongly, which is why a large focus is on caregivers. And this particular caregiver talks about the challenge of having to be the one to disclose the child's HIV status and having to be prepared to answer related questions. So she used the opportunity of a commercial to spark that conversation with her child, which she had delayed for several months, and the provider was constantly asking her, have you disclosed to the child? Have you disclosed to the child? Because that is often related to why some adolescents decide to stop taking their treatment. If they don't really know why they're taking pills, it's discouraging for them. So this caregiver said, when she was about to be an adolescent, I was told to sit down with her and explain that she has this disease. Hey, it was hard for me. I sat her down and there was an advert on TV. I don't know what it was about, but it said condomize or whatever, and she liked the advert. She liked it because she's a child. She did not know what the advert even meant. So I sat her down and explained to her, and the caregiver just went on to talk about how emotionally challenging the conversation was and had the number of questions that her daughter asked in terms of how did I get infected, why weren't you taking treatment, and really why do I have to take these pills, I don't feel sick. Appraisal support was mentioned as well, not as strongly as other forms, but this really has to do with caregivers reinforcing youth's autonomy. So it really encourages youth to be self-reflective and self-evaluative. So in this case, a caregiver said, I used to sit down with her when she did not want to take her treatment and ask her questions like, do you want to live? And she would reply, yes. Then I'd say, if you want to live, you must take your treatment. But if you don't want to live, then you will stop. So this was many conversations that the caregiver had with her daughter, who was frequently starting treatment and stopping. And she got to the point where she realized she really couldn't make her take the treatment. So she tried to help her to realize, look, it's really up to you. It's your decision. I really want you to take your pills, but I know that I can't make you. And when you're telling me that you want to live, then for you to live, you have to take your treatment. And she mentioned this as something really helpful for her daughter during her teenage years. While the overwhelming majority of participants talked about families as sources of support or facilitators of adolescent treatment retention and adherence, there were a number of youth who also mentioned the fact that families could also disrupt treatment retention and adherence. And this one talks a little more about the unstable home environment and child neglect. So the social worker here in this case talks about the fact that often when adolescents come to treatment, they come on their own, and providers might blame them for not taking their treatment, not understanding that there are a number of social factors that interfere with whether or not they're able to adhere. So she says, sometimes you think the child doesn't want to take treatment just because he doesn't want to take the treatment. But But if you dig into it, sometimes you find that socially, maybe the mother might be alcoholic, or there are some issues at home, or the child is being discriminated. So she just went on to say that it's really important for multiple levels of involvement, from whether it's social services providers and all of them communicating with each other to help you to be adherent to treatment, especially communicating with their caregivers. And she said, next steps for her often when she works with adolescents who are struggling is to make home visits to see what type of situation they might have at home. Another issue that was mentioned frequently had to do with lack of disclosure. Now, whether or not adolescents were disclosed to other family members outside of the caregiver had a lot to do with whether they perceived that they might be discriminated against, or whether family members had already said negative things about people living with HIV, so they didn't feel comfortable. I don't have this quote here, but we had a caregiver who talked about the fact that if something had happened to her or something happens to her in the future, because she's not disclosed to her family, no one knows about the child's HIV status, she's really concerned about what might happen to her son, especially given the challenges that he has with retention. And this quote is from a stakeholder who says, sometimes you find out a person doesn't want to be known by the family, so she missed out on support. And you'll find out the families, they want to help this person, but this person didn't want to be known by the family for quite a long time. So I think involving your family and not judging them, thinking they will talk badly about you, is critical. So this stakeholder just talked about the importance of opening up the conversation and not prejudging, saying that, they're not going to accept me, so I'm not going to disclose. This is just a summary of key findings. We are in the middle of analyzing this data right now and have also started with phase 2, which is to understand more about their social networks. So just a summary, key familial contributions had to do with social support in the forms of emotional support, caregivers as sources of HIV education, reinforcing adolescents' sense of autonomy, and establishing rituals ahead of time and planning during extended travels. And also, adolescents were heavily reliant upon their caregivers for reminders to take the pills. Familial harms included lack of structure at home, non-disclosure to relatives, and fears of rejection. So as I mentioned before, we're in the middle of examining social networks. And from what we learned from the transition program, as well as the data that we have here, is that adolescents really are looking for support from each other, from other adolescents who have HIV. And one of the things that we learned in the healthcare transition program is that many of them were attending weekly appointments, but they were not adherent to their treatment. And when we asked them why they were coming, aside from the good food, they said that they really found brotherhood or sisterhood with each other. So they were coming because they wanted to connect. So that's something that we want to explore in a participatory way. So we're doing social network assessment and hope to develop a participatory intervention with adolescents living with HIV. Just want to acknowledge study participants, our 3 research assistants, Fogarty program, as well as the Desmond Tutu HIV Foundation. Thank you.
Any questions? So I noticed in your slides, it looked like most of the support folks were older individuals in your cases. When I saw the ages, is it typical in that setting that a lot of the support is an older individual?
Yeah, because most of the support are coming from parents or grandparents. But in our interviews, we only asked about caregivers or their families. So the reason that we're doing the social network assessment is to see whether they reach out to other people or whether other people are essential in their treatment, retention, and adherence.
Nicely done. Can you comment a little bit more about your statement of being youth-friendly in approaching this and not being so much of the medical doctor?
Yes, so throughout the surveys, adolescents frequently commented that the clinic is kind of a scary place. They find that providers often shout at them, are rude to them. And when we talk to providers, they kind of take somewhat of a parental role when working with adolescents. So this kind of discourages them from adolescents' perspective from seeking sexual reproductive services, because if they ask for birth control, for example, a nurse might say, well, why are you even having sex, type of thing. So for the clinic that we're working with, there are a number of initiatives to help staff to kind of understand that adolescents aren't just small children, and that it's really important for their well-being, for there to be a level of respect. Thank you.
Thank you.